Allergy, being the fifth cause of chronic illnesses worldwide, has seen an exponential increase these days because of rapid urbanization, industrialization, air pollution, etc. Of the various diseases this term encompasses, those specific to children would be vernal keratoconjunctivitis and atopic keratoconjunctivitis. Although seasonal and perennial conjunctivitis can happen in any age group, they are more common, but they are less sight-threatening when compared to VKC and AKC, which are more sight-threatening but fortunately less common. It's the allergen which triggers the cascade of reaction, cascade of inflammation. Apart from the usual allergens like pollens, mold, dust mites, etc., in children we need to always consider the possibility of a food allergy. That is, whether the parents have included any new food into their diet has to be specifically asked for, especially proteinaceous food like seafoods or shellfish in particular, and peanuts. Even pineapple has seen to cause allergy in many children. And one factor is that some external factors causing allergy needs some time. That is, the children need to be, they present with allergic conjunctivitis only after the age of 3 to 4 years because it needs exposure, sensitization and re-exposure. Whereas those allergy which are internal, they present usually, or intrinsic kind of factors, they present very early even in infants. As has been mentioned, this is a type 1 Ig-mediated hypersensitivity where the allergen is being exposed to the conjunctiva. It triggers a cascade of reaction where the Ig is presented onto the surface of the mast cells, and on re-exposure the mast cell degranulates, releasing the histamine and other chemicals. Allergy does not target a single organ. We need to always remember to look for other respiratory allergies or skin allergies in all children with allergic conjunctivitis and treat them as well. Typically, the signs and symptoms of allergic conjunctivitis should be bilateral because of the activation of inflammatory cells, though they may present unilateral because of the asymmetry. Itching is the hallmark symptom of allergy, and this is caused by when the histamine binds to H1 receptors on the nerve endings. And when histamine gets attached to the H2 receptors in the blood vessels, it causes more of vasodilation, redness, and lacrimation, etc. Among the signs, the papillae being the most characteristic sign of allergic conjunctivitis is because of recruitment of neutrophils and eosinophils. As I said, ocular itching is the pathognomonic symptom, so much so that if itching is absent, the very diagnosis has to be questioned. I need to speak a few words about vernal keratoconjunctivitis as we are speaking about pediatric allergic conjunctivitis. This is a chronic severe allergic inflammation happening in children and adolescents. In hot and dry climates, boys definitely have a preponderance of ratio of 3:1, and 50% of these children have atopy as well. The children present with incapacitating itching, even knuckle itching, and when cornea is involved, they present with photophobia. 3 clinical types have been classified. One is the limbal, where you get the gelatinous infiltrate around the limbus, and the palpebral, where the most characteristic sign of cobblestone-like giant papillae. They are flat-topped, polygonal. These are actually the cobblestones. So the papillae resemble these cobblestones, and therefore with tenacious discharge, this is characteristic. So it's very, very important to flip over the eyelids in children who present with red eyes. The cornea gets involved, starts as punctate keratitis in the center, then they coalesce to form macroerosions, which later on becomes plaques, which causes central scarring and diminishes vision. Pseudogerontoxin, as we all are aware, is an arcus-like picture which presents an opacity near the limbus, and Horner's Trantas dots are typical dot-like infiltrations at the limbus. The interesting fact is that the more the Horner's dots, the more severe the disease is, and these dots are present only during the active stage of the disease, and they disappear when the symptoms abate. Shield ulcers, as Dr. Anil mentioned, are oval ulcers, non-infectious, seen on the superior aspect, and these lead on to stromal scarring. Talking a few words about atopic keratoconjunctivitis, this being the ocular counterpart of atopic dermatitis or eczema, eyelid skin is usually involved with chemosis and fine sandpaper-like texture. It also causes a complication of atopic cataracts. Other than that, the clinical features of AKC and VKC are very much similar, but VKC resolves by the age of 20 years, whereas AKC may persist throughout life. Yet another hypersensitivity, delayed hypersensitivity allergic reaction seen in children are to endogenous microbial proteins like tuberculoproteins, staphylococcus, some parasites, etc. That is Flictonella keratoconjunctivitis, seen as well circumscribed nodular lesion, nodular inflammation at the perilimbeal area. This has a preponderance for female for a change. It is quite distressing or frightening to know that a condition as simple as allergic conjunctivitis can lead on to sight-threatening complications. One of them we have already mentioned is the corneal ulceration and scarring. Next very important thing is a steroid-related one where we need to resort to give steroids. The cataract, glaucoma infections, as we are all very familiar. Limbal stem cell deficiency and keratoconus has said to be a main complication of ocular allergy and eye rubbing because they are shown as key contributors in the pathogenesis and even in the progression of keratoconus. Eye rubbing has shown to alter the ocular surface proteins and increases tissue proteases, which have been very well proved with various lab techniques. Allergic conjunctivitis is one of the most underdiagnosed and most undertreated condition among children, but diagnosis is primarily clinical, though we can do some skin tests or scratch tests to identify the allergen, and tests to identify the antibody, IgE antibody are available. In the treatment part, as mentioned already, avoidance of the offending allergen is the most important thing, and as doctor specifically mentioned, we need to ask the children to wear plain glasses, which helps in two ways actually. It prevents the allergen exposure to the eye. Also, children are reminded not to rub their eyes as well, which I am coming to later. And primordial behavioral modification like hand hygiene and not letting the pets come inside and sleep with them and things like that have to be taken care of. Among the pharmacological treatment, I would like to specifically mention about the addition of artificial tear drops in the management of allergic conjunctivitis, particularly in children, because teardrops actually help in a long way. They form a barrier on the conjunctival and corneal surface, therefore acting as improving the first line defense. Second thing is they dilute the allergen and the inflammatory mediators and flushes out the allergen. So it soothes the eye a lot and therefore helps the child in preventing, avoiding rubbing as well. So we need to always add an artificial teardrop along with other medications. Usually they can be treated, mild ones can be treated with topical antihistamines and mast cell stabilizers. We need to always remember that the olopatadine and alcaftidine and similar drugs, the safety of these drugs have not been established in children less than 2 years. And NSAID drops and corticosteroids have to be given in severe infections, and immunomodulators like cyclosporin A and tacrolimus. Surgery has to be resorted to in conditions, in severe conditions like superficial keratectomy, amniotic membrane graft, etc. So the most important key point in the management of allergy, particularly in children, I would want to emphasize is about avoiding rubbing of the eyes, because rubbing augments the intensity and the duration of itching, chemosis and hyperemia, the symptoms and the signs, because rubbing causes release of more histamine and the eyelid and eye inflammation as well. So how to help them? Tell them to wash their face very well and use cold compresses. It really helps them to relieve the symptom of rubbing, itching sensation, and therefore unless they stop the rubbing, the vicious cycle cannot be stopped. There is more rubbing, more histamine release, more rubbing, and the cycle continues. Therefore we need to insist that they would stop rubbing. The parents have to be told, and I usually tell the children itself that they can, even if they are in the school, they can ask permission and go and wash their face, and that helps a lot to get the symptoms completely relieved. So talking about pediatric allergic conjunctivitis, it's one of the condition with it's a preventable vision loss. We need to think about that, and which affects the academic performance and quality of life. Hence a very prompt detection, diagnosis and appropriate management is very important. Thank you very much.
So second time lucky, I guess. So thank you so much.